Hello and welcome to the Princeton Spine Joint Center podcast. My name is Zinovy Meyler and I'm the co-director of the Interventional Spine Program here at Princeton Spine Joint Center. We just finished recording a podcast with Sunita Mani, who's a physical therapist and the Director of Outpatient Rehabilitation Services at Plainsboro Center for Princeton Medical Center. We had a really good in-depth conversation about McKenzie Method. McKenzie Method is a method of treating primarily the spine, or at least that was the focus of our conversation. And if you have any interest in treating the spine, if you have any issues with the spine, if you have any loved ones with issues with the spine, you would find this conversation very helpful and very useful because we delve into the importance of ergonomics, posture, the approach of McKenzie, what it's based on. Also, we talk about how to be a better physical therapy patient. Essentially, what does it take to get as much out of the treatment as possible? And as this approach implies, this can apply to anything. And if you have ever gone through any kind of rehabilitation, taking an active role in your care and specifics of that, as we talk about in this podcast, would be very useful for you. So, enjoy. Hello and welcome to Princeton Spine Joint Center podcast. My name is Zinovy Meyler and I'm the co-director of the Interventional Spine Program here at Princeton Spine Joint Center. Today joining me is Sunita Mani, who serves as Director of Outpatient Rehabilitation at Penn Medicine Princeton Medical Center. Sunita, welcome.
Thank you.
So today we're going to talk about McKenzie Method. Before we dive into the topic, I wanted to get a little more information on you, and I know we've worked together for years, but just for our listeners to understand your background and what your interests are and so on. So I think the easiest way to start with that is to go over the multiple letters that follow your name.
Sure. Like you mentioned, I'm a physical therapist. I'm the Director of Outpatient Rehab at our Plainsboro campus and our South Brunswick campus as well. I do have a doctorate in physical therapy, as well as I'm a certified ergonomic assessment specialist. So a lot of my practice does focus on patients with low back injuries, patients with cervical injuries, with the special attention to body mechanics, biomechanics, and posture.
Cool. So the whole spine.
Yes.
Got it. And and that's going to be very important for us to discuss McKenzie Method and generally spine mechanics in the context of presenting symptoms. How did you get into physical therapy?
Well, actually, it's interesting. When I was 16 years old, it was one summer, I had nothing to do. So my parents, who are both medical professionals, said, well, why don't you volunteer at a hospital? So I said, okay. And then they put me randomly in the physical therapy department. Prior to that, I wanted to be an attorney. I didn't have any real interest in healthcare. So they put me in the physical therapy department. And I was like, okay, I'll do it for like a week or so and we'll see what happens. I ended up spending the entire summer there because I really liked it. What I liked most was to see the patient progression, to see when they came in and how debilitated they were, how much pain they had, how much they couldn't do, and the focus that the therapist spent with the patients, focusing on the things that they wanted to do, and then them kind of like, reclaiming what they wanted to do and getting to their goals. So that was really motivating for me. And then the year after is when I had to apply to college, and I ended up applying only to physical therapy programs because I was very committed to doing that after I saw the difference that can be made from this field. That's
a good thing you had nothing to do that summer. Yeah. That's cool. So, and then how did you end up getting more training in ergonomic assessments and interested in that?
Yeah, well, it all started actually, when I first came out of school, I took a lot of different courses specifically focusing on manual therapy because that was a strong interest of mine from the beginning. So I took several different ones, and I don't necessarily think, some are better than others, but I do think that in the various ones I've taken, when I've taken the McKenzie courses, they were really very readily applicable. You can kind of implement them right away after the course was done, and patients really did fit the subcategories and present how the literature showed that they would. Not 100% of patients, but the vast majority did. And it was just a clear way to assess and, evaluate, and treat these patients. As I kept going, I noticed that posture was such a big role. It played such a big role in these people's lives, in people's lives in general. Overall, people just don't sit properly. They don't bend properly. They don't lift properly. So this was something that, I realized had to be a focus of the treatment that we do in order for there to be any sustained benefit in what we're doing for these patients. Like, we had to learn about more effective ways to use our bodies and to sit properly and how to recruit the proper muscles, and then educate our patients with that so that they're equipped with what they need to do, so that when they're done with us, they can use these skills, including posture, and go back and live their normal lives, but do it better and more efficiently. And then when I got my ergonomic assessment certification, I did, do quite a bit of different ergonomic assessments at, various places in the hospital, where, people would complain of, back pain or shoulder pain or neck pain, mostly people with desk jobs. So they'd be sitting in one place and the computer's over here and the phone is over here, and
Right.
everything just wasn't right. But it's such simple fixes that you can make, but you just have to know what to know, and you have to know, like, the proper way of sitting, the proper spinal alignment, things should be within arm reach, feet should be on the floor, hips and knees at 90 degrees, things like that, which once you know it, it all seems pretty basic. And once you put these people in the proper alignment, they really pretty quickly feel better, because if you try to, if the tendency is that we're going to do what we do and we give them exercises and we, mobilize their spine and we strengthen their core, but then they go back to their 9-to-5 job and they're sitting poorly, and then they get on the train and they're standing with a laptop bag on their shoulder, it's going to undo everything that we just did. So the better they're educated and they're equipped in what they need to do and how they need to stand and position themselves, the better they will be overall. So that was like a big interest point of mine, just because I needed to know what to know in order to educate my patients in that regard.
That's a great point. I mean, the ergonomics are so tremendously important. And when I talk to my patients, and most of them are mutual patients, no matter what they do, they're going to end up in front of the computer, right? I mean, you and I end up in front of the computer.
Right.
Everyone uses a computer in one way or another, whether it's to get news, to do their work, and so on. And so the statistics are staggering against us, right? I mean, it's over 80% of people will have some kind of a spine type of an issue. And this isn't just U.S., this is across the world, because International Rheumatological Journal just published a study looking at a number of developed nations, and that statistic really applies across those nations, or towards 80%. So definitely in terms of the ergonomics, that's huge.
Yeah.
So before we dive into McKenzie specifically, which really pertains mainly, or at least we're going to talk about the spine implications, what else at Penn Medicine at Princeton Medical Center, what else do you see? What type of patients? Are there any subspecialties for physical therapy?
Yes, we have 5 locations as part of Penn Medicine Princeton Medical Center. We have one in Plainsboro and South Brunswick. Those are my clinics. We have one in Princeton, we have one in Hamilton, and we have one in Monroe. The different specialties that we have are across the different clinics. We have aquatic therapy in 3 of our clinics. We have pelvic health in 3 of our clinics. Everyone treats general orthopedics, postoperative care, spine. We have hand therapy in 2 of our clinics. We have concussion, vestibular specialists in 3 of our clinics. We have lymphedema in 1 of our clinics. So there really is a host. We have dance medicine in 3 of our clinics.
Right,
We have LSVT for patients with Parkinson's disease in all 5 of our clinics, actually. So there really are a variety of subspecialties. And the great thing, I think, at least, with the therapists that I know, which are a lot of them, they're so invested in the field, and they're so invested in their own betterment and, improving their education and what they know and their skill set, so that we can help more and more patients along the way. So I've been with Princeton now for 7 years, and even over those 7 years, the subspecialties have increased tremendously, because there's a community need that we've seen, and then we've kind of gone after it and gotten the education so that we can serve the needs that we see.
Awesome. And that excitement kind of translates into better outcome almost, right? Because anytime I connect with any of the therapists at Penn Medicine, it's always been very much patient oriented. It's always, okay, we've gotten this far, how can we get further? And let's look at it from one aspect or another. And it's great that they come at it from this kind of a group, the mentality of a team.
Yeah.
Right? So that if we need to order any kind of additional diagnostic studies, we can do that, and then it's really working out for the patient.
Right. Yeah.
So awesome. Let's talk about McKenzie.
Great.
So what is McKenzie Method? How did it come about?
So Robin McKenzie was a physical therapist, and back in his day in the 50s, the standard of care was you flex the patient. So a patient had low back pain. The typical thing that you did was have a patient lie on his back, and then his knees would come up to his chest, and rotation side to side. And I'm not saying that that's not appropriate, but that was kind of just the generally accepted way to treat all patients with back pain.
Sort of a cookie cutter approach?
Yes, a cookie cutter. So this one day in his clinic, he had a table, a treatment table, that was upright. So typically when patients would lie on that table, you would lie like sort of in a semi-reclined position where your back is there, your legs are in front of you, and you're lying down. So he told this patient, Mr. Smith, go into room 2 and lie down. So I guess he wasn't very specific. Mr. Smith is like, okay, let me go lie down. So he lied down actually on his stomach. So he ended up being in a pretty extended position instead of the flex position that everyone was accustomed to. So Robin McKenzie took a little bit of time doing whatever he was doing, and then he went into the room and he was horrified because he was like, oh my gosh, this patient's now going to need surgery. I've totally destroyed his back. So he gets off the table and he's like, oh, thank you. I feel great. And he no longer had symptoms down his leg. So that was really groundbreaking at the time because nobody was doing that. So then he started to think like, okay, wait, why did this work? Then he started doing extensive studying into this whole phenomenon. Like, why did his symptoms go from his leg into his, it totally abolished, it went away altogether. But why did that happen? This is against everything that we know. So then he started doing the research, and then over time they started, we started getting a group together, they started doing more and more, and then they developed the principle, which is a phenomenon called centralization. It works so tremendously well, and it really works the vast majority of the time. And the phenomenon of centralization is when you have symptoms that go into the leg or into the arm, in case it's, if we're talking about the neck, the goal is to get the symptoms out of the peripheral joint back into the origin, which is the spine. The way that we know that we are reducing pressure on the nerve that's being impinged is by the patient's symptomatic response. So if the patient responds like, oh, I did have tingling in my leg, but after I'm doing this, now it's up to my knee. Oh, now it's in my buttock. Now it's just in my back, but it's intense. I think this is something that patients need to be super aware of. And this is something I tell patients all the time. If we ask a patient, does it hurt or how would you rate it? That is really important, and that gives us a lot of clues. But it's also extremely important to know where the symptoms are. So if the symptoms are starting in the leg and it's about a 5 out of 10 in the leg, but now it's all in the back only and it's an 8 out of 10 in the back, while the patient might perceive this as worse because the back pain is now an 8, whereas before it was just a 5, I always tell patients that an 8 out of 10 in the back is better than a 5 out of 10 in the back, thigh, leg, and foot. So it's better, even if it's increased intensity, to have a centralized area of pain. So the goal of the McKenzie method is to centralize your symptoms. So like I said, bringing it towards like the center, so the origin, and then ultimately to abolish it altogether. And the way that you do that in the McKenzie method is by doing a series of different tests. And it's a very sort of like regimented approach to patient assessment, which I like, because if you've been McKenzie trained, it's a very systematic way to do it. So you would have the patient go into specific repeated motions. And first you would start with the sagittal plane. So you would have them do repeated extension. Typically you start with extension because typically disc derangements or herniations or bulges are usually posterolateral, which usually presents itself that extending makes it feel better.
Sorry, so when you say sagittal plane, that just to be clear, it's forward and back.
Yes.
Just for our listeners.
Sorry.
So
Yes.
it's flexing forward and extending back.
And extending back. That's right. I think a misconception of the McKenzie method is that it's all extension, that it's all like standing, bending backwards, lying on your belly, pressing up. And while the vast majority of the time that is what works for patients, because the majority of the time that is the direction of the disc derangement, and the way to reduce that derangement is by putting the spine into that position, the McKenzie method is actually just repeated motion and sustained motion either way. So it could be bending forward, it could be leaning back, it could be gliding side to side. But typically in the assessment, we would start with backward bending, and then we would have them do about 10 to 15 of those, and we assess the patient's symptoms. So if the symptoms have come up or reduced in intensity, gone away altogether, that's a green light. If it stayed the same, that's kind of a yellow light. If it got worse, like now it's into the leg and it's worse and we have a 10 out of 10 everywhere, well, that's a red light. So typically with red lights, you just go the opposite way. So then we would try flexing, and then we see what happens to the symptoms. The word of caution that I would say is oftentimes while flexing can feel better on the back because it does separate the joints in the spine, it also can further herniate or further protrude or cause an increased bulge of the disc a lot of the time, depending on where the bulge is. So again, I can't enough stress for people to be aware of where the symptoms are, not just the intensity of the symptoms.
Yeah, absolutely. And same goes for whenever I do any kind of diagnostic testing, whether it would be a clinical exam, but even more so when doing diagnostic blocks. Like you said, the facet joints. If you put medication into the facet joint, I usually will provide the patient with a pain diary to record improvement. But I always tell them it's so important that you talk about your general pain. but even more important, talk about the specifics. Because sometimes you may be considerably better in one aspect, but not another, or not better in one aspect and better in another. And that really guides us
Right.
in terms of what is going on, not only because of what's going on with this, but also majority of patients will have this chronically. And after a while, there are compensatory mechanisms that now it's not just one thing, but it's a domino effect, right? So
Right.
you see, you have one thing and then the other. So that discussion definitely permeates, and I think it's from clinical in interventional and McKenzie, and I'm sure everything else that any other approach in physical therapy that you would do.
Yeah.
Right.
Yeah. And speaking of, you mentioned chronic. So oftentimes, like chronic back pain, like you said, 80% of people, and in a paper I just read published in the UK, it actually said like the 86% is what I saw there. So I was like, oh, geez. And I thought the same thing you said. I was like, so this is not just US, this is sort of everywhere. And I think because sitting is so prevalent in our culture,
Right.
like whether it be sitting in front of a computer or like sitting watching TV or, whatever it is, and people just don't sit properly. Sitting, and I tell patients this all the time, sitting is the position that puts the greatest load on the discs in your spine. So if you already have issues with your disc, if it's, if you have a derangement, if you have a bulge, if you have a protrusion, whatever it is, sitting will further increase that pressure. So further cause, as I tell patients, smushing of the nerve, which is going to cause like the radicular, the pain into the legs. So if you're not sitting properly, there really is a good chance that you're kind of undoing any other good that you might be doing throughout the day. So I often tell patients too, like we see patients for, an hour a day, right? And so we're doing like in that hour, we're often doing exercise plus manual therapy to do what we can do to either, regain their motion, increase their core, improve their flexibility, decrease their pain ultimately. But then if they go home and they're not like maintaining like the things that they need to be doing, or they're not aware of things like their body mechanics and their posture, we're doing what we're doing in complete vain. Like there isn't any benefit, because a lot of it does fall on the onus of the patient. And that's another thing that I really do like about the McKenzie method, is that it places a great deal of ownership on the patient in his or her own recovery. And I think that's great. So like one of the things that McKenzie talks about is, if you have an acute bout of low back pain, where not just low back pain, but specifically low back pain with radiculopathy, meaning pain that is going into the buttock or into the leg, the first thing that you should try to do for the vast majority of time is lie on your belly. So lying on your belly and then pressing up onto your elbows and just hang out in that position. And again, pay attention to what your symptoms are doing. So initially, after we assess patients and we see that whichever direction is their direction of preference, has been reducing the derangement or, decreasing their symptoms in their legs, we tell them to go home and do that. But the key is that you need to do it frequently. So frequently means like 20 to 30 of these every 2 to 3 hours, which seems like a whole lot, but in reality, it doesn't take very much time at all. Just because it's not an extensive exercise program. It's just like 1 or 2 exercises to be done frequently.
And that's a very important point also that I try to convey to patients. I tell them this. You and I meet, patient and I meets once, say, a month. I say that it's very, very important for them to really vocalize their symptoms, their recovery, and everything else to the physical therapist they're working with, because you're going to see them a lot more frequently. But even beyond that, you're only with them for an hour. Mm-hmm. It can be an intensive hour with a lot of work, but there are so many more hours in the day and in the week that you cannot be with them. And if they don't take the ownership of that, of their own issue, it's not really going to progress, and you're going to be making several steps forward and then taking as many steps backwards.
Yeah.
And to your point about the disc pressures, and this is for our listeners, we know those disc pressures not just from experience, but actually from studies. The Neckerson studies in 1960s, where a manometer was inserted into the disc of likely college students, and there was a good number of patients. We learned about the different positions, and from there we know how much pressure actually is in sitting. And granted, that study was actually validated. I believe there were 2 patients that were in a follow-up study in 2000. So because I think IRB approvals are difficult to obtain to stick a manometer into patients' discs, but we know that from studies. So this is whenever we say that there is a lot of pressure in the disc when sitting, this comes out of actual scientific evidence that is actually true and that does need to be addressed. And the fact that we're sitting for so long actually is detrimental to our back, and anything we can do to change that is important.
Right. And that's something too I tell patients all the time. If someone has an acute flare-up of low back pain with pain that goes into the leg, I will often tell them to try to avoid bending, try to avoid sitting for a prolonged period of time until we can get these symptoms under control. With that being said, I realize that that's not always possible because in our daily life, you have to sit.
Right.
Like, there's daily activities that we have to
Right.
do where you have to sit. And sometimes these people are not able to be out of work, and their work might be sitting in front of a computer for 8 to 10 hours. So if they have to do it, they have to do it. But there are ways around it that you can manage that you can be more successful in doing what you need to do. So for example, I'll often recommend them using a lumbar roll. I mean, I have one in my office, I have one in my car. I think it works tremendously well for people with low back pain. It is so simple. I wish I invented it because I recommend it all the time. It's just a cylinder, and it's made of a really good quality foam. You put it on the back of your chair, and as you're sitting, you put it like pretty much at the level of your waistband. So it reinforces your lumbar lordosis, so the natural curve in your low back. And it prevents you from slumping down further. So while you're still sitting and while you still do have that increased intradiscal pressure, it does maintain the curve better than if you don't, and it doesn't allow you to slump and slouch, which is why I recommend it all the time. People often feel like it's comfortable because I'll have it in my office or like my clinic, and people will sit with it. They're like, oh, this feels good. But it feels strange because people are not used to sitting up like perfectly straight all the time.
Right.
But the great thing about that is that you don't have to consciously think about doing it. It does it for you. Anytime I've given a community lecture on low back pain and we talk about the topic of posture, whenever you say the word posture or the slide comes up, everyone automatically like sits up straight, right? That's what you do. But in reality, you can sit up straight for like, I don't know, maybe 20 seconds if you're good, and then you're going to just poop out right away, just because our core muscles, our postural endurance muscles are just not equipped to do that because they don't have the endurance because we don't do it. They're certainly trainable, but that takes effort. There's certain exercises that we do in physical therapy to enhance pretty much people's motor control and their awareness of their own posture. And we've heard from patients multiple times, like, by doing that, it increases their awareness when they're sitting at their, a bleacher for their kid's basketball game, and they notice that they're sitting poorly. They're aware of it so that they can correct it. And that's great. That's exactly what you want, is just to improve the awareness so that they know they're doing it. You can tell people to sit up straight and then they think they are. But if they don't have the muscle endurance to maintain it, then they're not going to be able to. And then whenever you are able to sit in a chair with the back, like if I have patients who travel for work and you need to travel extensively, so you need to sit on a plane, so you can't avoid it all the time. But there are ways to modify it so that you can preserve the integrity of your back while still doing the things that you need to do.
Do you tell them to take a roll with them on the plane?
Yeah, I have many times.
Yeah.
I've been in airports before multiple times, and I've seen people with rolls, and I always think like your therapist would be so proud. That's always what I think. So, but it's really very beneficial if you have to sit for a long time.
Well, let me ask you, how do you feel about this, specifically about posture? What I usually tell people is that what I see is that the monitors that they're using are too low, they're off center and so on. But one of the main things when I ask them to simulate their work environment is that their monitors are a little too low. And what I tell them is essentially the way we are going to move is going to follow our eyes. And so if the monitor is too low, then our eye level is going to go towards the center of the screen, essentially, and that's where majority of the work is going to happen. And then the head is going to follow, the shoulders will round, and then the back will round. And so some of the things, I actually have had several patients that I recommended sit to stand desk if that's something that they can do, where I don't think that standing all the time is the answer. But changing the position is a great thing.
Yeah.
But they say, well, my shoulders kind of hurt. Well, I try to explain that the relationship between the shoulder, the arm, the neck, and the head doesn't change whether they're sitting or standing. So now they need to make sure that ergonomics are set up appropriately for the upper body, so that when they go to stand, that they're also upright and not being dragged down. Do you think, does that...
Yeah, I think that makes complete sense, because you're right. If it is too low and your eyes are low, you will eventually follow, especially after a super long day. Like you're not going to be able to maintain proper posture. And those are things where an ergonomic assessment would come in, where it could be such a simple fix, like put something under the computer to raise it, or lower this chair if you can, like things like that, just to get you more like eye level, so that you don't have to either look up all the time, putting an extensor moment on the neck, or look down all the time, thereby increasing your whole kyphosis of your spine. So I think that there's like tweaks that you can do, but yeah, I definitely think changing positions, if you're not able to do that kind of stuff, I do think changing positions is a really good recommendation. I've told people many times, like, put an Outlook reminder in your calendar, like every 45 minutes to an hour, just stand up, just like, go get water, or like just break up the posture, because sustained posture is just not ideal, like especially for such prolonged periods of time, like a work day.
And that also serves as a reset, because we develop a lot of habits, right? And some of the things are just habitual. You're habitually going to get into a position that is comfortable for you, quote unquote comfortable, because comfort is really relative to the moment, but not necessarily for longevity of your spine and longevity of your career.
Right.
And so getting up and changing the position, getting back into sitting position, you're more likely to assume a better position because you're getting up to change the stress on your spine itself. So I especially for flights, I usually recommend for flights, break up the flight. You have a 6-hour flight, and change that. I think a lot of it is habitual, and this is one trick I also learned from physical therapy, working with physical therapists, is that for people that drive a lot, right? I tell them, set up your seat so that your eye level is about the middle third of your windshield, and then set up your back view mirrors, and then don't touch them. Because the next time you try to reach for a mirror means that you've slouched down and means that you've slid down. Adjust your posture so that you now can see, as opposed to adjusting the mirror to your new slouched posture.
Right. Yeah, I think that's a great point. And then it also increases your awareness. Like if you know that you're not supposed to touch it, then you have the awareness of like, okay, wait, something is off, and then you right yourself so that you are able to see the way that you did when you were sitting with proper posture.
Right.
So yeah, I think that's a great tip. And I would just add to that to add a lumbar roll in your car.
Yeah.
And a lot of times, like
Sure.
patients have said to me, like, I have like a built-in lumbar support in my car, like my driver's seat. And I mean, I do too. But I think if you've had back issues, it's often not enough. Even if you put it on like the most support that it can offer, it still would often benefit people to have a lumbar roll on top of that. So.
Sure. Yeah, I doubt that there's any car seat that would simulate a lumbar roll.
Yeah, I can't imagine it would be that much, because lumbar roll is pretty thick, but it's good. It's really beneficial in putting your posture the way that it needs to be.
So when someone comes in to see you, and you're going to apply the McKenzie Method, right? And what does a patient go through? You mentioned assessment, and you mentioned that there's going to be work. Is there a reassessment as they go? Is this something that progresses and certain goals are moved as there's progress?
Yeah, so it's kind of, McKenzie's also very big on constant reassessment. So, you first do your assessment and you have them go through, like I said, the repeated motion testing or the sustained motion, and you see what helps their symptoms. So let me backtrack a little bit. There's 3 different syndromes that McKenzie classifies patients with back pain. There's derangement, which is the most common. Derangement is a rapid response to positional changes. So if I come in and I have pain down my leg, and you flex me forward, and I'm doing this 10 times, and now it's more intense and further down my leg, and then I go backwards and it's less intense, or it's coming up higher, that is a derangement because it is responding very quickly to what we're doing. The second is a dysfunction. So dysfunction is typically, there's a limit in motion, and you get pain only at the end range of motion. Dysfunctions do well, but they take longer to do well, and they don't respond as quickly to pain or to movement. So if a patient comes in with back pain, they lean back, it's fine. They have pain all the way at the end range, they come back to the middle. They lean back, pain only at the end range, and they come back to the middle. That is typically classified as a dysfunction, and you work further into that range to increase their motion.
Okay.
The last is a posture syndrome. Posture syndrome would be a dream to treat. I've been a therapist now for 15 years. I've never seen it. It's very simple. It's literally people with poor posture, and that is what is the exclusive cause of the pain. So these are people typically teenagers who just sit really poorly, or people with desk jobs who sit really poorly, but their symptoms only happen when they're in that position. So their movement testing is going to be totally fine. They have no range of motion issues. They have no strength issues. They don't have pain when they're just standing, and or during the evaluation they probably don't have pain. But if you were to ask them, when do you have pain, and they can say when I'm at my computer. Okay, what do you look like when you're at your computer? And if they simulate the motion, that's when they get their pain. So for those folks, the best treatment, the only thing that you would do is to right their posture, to increase their awareness, to build up their core muscles, to build up their scapular retractors, to open them up and to get them erect and upright. So those are the 3 different syndromes. So if I'm seeing a patient, again, typically for derangement, because these are the people who have symptoms in the leg that do respond to the difference in mechanical loads, we would do the assessment. We would see what we see, in what category do they fit. So if extension, and again, I'm using extension because it's the most common, if that is the one that, tends to centralize your symptoms, we would go right into treatment, right? There's no reason to just do the evaluation and send them on their way, unless for whatever reasons, but typically we would go directly into the treatment. So we would have the patient start, and I would give them, whatever exercise, and we see what the response is after that. And then typically we would do many of what we just did. Now, if the repeated motion is not making any sort of change, then we would try sustained motion. So for example, having a patient, on like that elevated plinth the way Reverend McKenzie did when he accidentally discovered the method.
Right.
So having a patient in that position with, lumbar spine extended or like propped on, his or her elbows, that sort of thing, just to get the extended, prolonged load on the spine into the direction that they typically don't go, but the direction that is still improving their symptoms.
How long would you keep them in that position just to see that this is actually making a difference?
So typically we would start at probably 2 minutes or so just to see. Now, a lot of times people will complain that they have pain in that position. But again, that's when we go back to what we said before, is that we have to have them specify, where do you feel it? How is the foot? And if they're like, the foot's okay, but the back's really killing me, then we're like, well, that's good, And so we try to explain to them, getting the symptoms up higher is what is ideal. So if you're feeling it up higher, the goal is not for you to feel it up higher forever. But right now, if you're feeling it up higher and not lower into the leg, that is what we're trying to do. So we really try to impress that upon patients. And that is a hard concept for people to understand. And I get it. It's counterintuitive. If this is hurting my back more than when I came in, why am I doing this? So I understand why that doesn't quite make sense, but it's just a process of getting them to understand the anatomy of it and the pathology of it. What are we trying to do mechanically here? And oftentimes they do. Oftentimes, I think a reason why the method really does work well for people is that people do see the results themselves. So if I tell you that, doing this will, make you more handsome, and then if you do it and you look in the mirror and you're like, I do look more handsome, then you're more likely to do that all the time, right?
Sure.
Because you like the result. So this is, obviously a different case, but it's a step further because low back pain can be so debilitating, as anyone with low back pain would attest to. So if they see right away that this is making the symptoms better, it still might be difficult for them to do it as often as prescribed, but it is more likely that they will have the inclination to do it because they see that there is something to this. I do feel better. My leg isn't as painful, but again, it really is just, it is a process of understanding what the mechanics, what the goal and what the anatomy is behind it for them to truly.
It's awesome, and it's great to get instant gratification. Is great. To me, it feels like it's great during the therapy. It is to some extent a double-edged sword. I find when I see people coming back, and we'll touch on that in a second, because this has a lot to do with when you get immediate gratification. That's wonderful from the patient standpoint. The downside is people are thinking, and I wouldn't call it a downside to this, but when someone gets better, and then there is nothing to compare it to, getting them to do something continuously and do it in a preventative fashion, it has to be an unsung hero, because the way they know that what they're doing is working is the fact that they're not feeling anything, which is. Pain is a great motivator, right?
Yeah,
when the pain goes, unfortunately, people lose the motivation to do the things that keeps the pain away.
Right.
And so we'll touch on that in a second. But I know that you've already mentioned, but to drive that point home, I think, or maybe to expand on that, in your opinion, what would make a good physical therapy patient? What advice would you give to a patient going through physical therapy to get the most out of it and to be a good physical therapy patient?
I think someone has to be willing to take ownership of their own healthcare. We are there to help, and that is my entire goal, is to help these patients feel better. I've been on that end where I've had back pain myself, and I've had a therapist who was really great, but I was very invested. I mean, I come from a different perspective, but I was also really invested in my own betterment. I wanted to get better. I wanted to get better quickly because I had to go back to work and help other people get better. So for me, the ideal patient is someone who comes in and they want to learn about okay, what exactly is happening? Why am I getting this pain down my leg? And why is it better if my back hurts, but my leg doesn't? And what do I need to do? How, people who are compliant, and people who are aware of paying attention to their symptoms. I think symptoms are very important. I think no pain, no gain is not true at all. For the vast majority of things, it's not true. For the back, it's definitely not true.
Right.
So I think you have to be mindful and respectful of your symptoms. And then I do think that you need to, acknowledge how they're responding and then move past it. So, it's not necessarily if something hurts, don't do it. It's not quite that simple, but it's just an awareness of where does it hurt? Is it better? Is it worse? What is the location? What is the intensity? So someone who is willing to kind of put in that time, and someone who is willing to okay, yes, I realize for the next 2 weeks, I'm going to have to do this every couple of hours at home 20 to 30 times, and that's going to be a really big pain. But if this is what I need to do for the next 2 weeks consistently, then that's what I'm going to do. And I've often told patients, back to what you were saying about pain is a great motivator. So if you have pain and you see this makes it better, you're more likely to continue it if that's what's making it better. And that's great, right? But yeah, once it feels better, are you as motivated to do it as consistently? Probably not. But I've explained it to patients before, think of it like a vitamin. Think of it like your blood pressure medicine that you're taking. It is just something that you do need to continue to take to maintain where you are right now. So you can't afford to just stop. And it is something like, particularly if you're going to do something like a higher level activity, if you're going to do something that does require a lot of flexing, or if you're going to do something that does require you to lift or bend in certain ways, it is something that you can do prophylactically to prevent an exacerbation of the symptoms. So I've often told people if they have to sit for a long period of time, to do whatever exercises they are, the repeated or sustained exercises prior to getting into the car, do it after you get out of the car, kind of like couch the activity that's not ideal with the stuff that you're supposed to be doing. And that's all you could do is modify your life around the activities,
Yeah, it's an interesting conversation to have. I mean, it's great that part of the McKenzie, right, and just generally part of treatment is education, right? I mean, you are educating the patient so that they can understand what's going on, what their expectations are, and it makes it easier and less frustrating to go through the process, right? And it does require a lot of buy-in from the patient, which sometimes is a bit of an uphill battle, right? But it's also interesting to have a conversation when someone is better. Yeah. And I'm certain you've had these conversations. I certainly have had multiple conversations where someone says, okay, great, I'm doing much better, thank you so much. And we start talking about, well, now you need to have a maintenance program. Now you need to be aware what brought you here and what can bring you back, right? And then the question inevitably is, well, does that mean I have to do these exercises for the rest of my life? No one questions brushing their teeth for the rest of their life, right? So I mean, that's maintenance, right? So the same thing. And by the same token, the conversation also sometimes goes into, well, but if I do this, am I definitely not going to have pain again? Well, we can't really guarantee that. It's also like you've had your cavity filled, and you brush your teeth. It doesn't guarantee that you don't get another cavity, but it certainly significantly decreases your chances of that. Yeah. And the same thing here. So it does require a lot of buy-in from the patient. So that's great advice.
Yeah, and we were talking before about statistics of low back pain. The statistics of recurrent low back pain, you're just so much more likely to have back pain if you've had back pain before, which is why it just continually increases, because mostly everyone has had a bout of back pain. So without doing preventative things, we see people all the time who they come in pretty debilitated. We do different things like exercises with the repeated motion, with the sustained motion, as well as manual therapy, modalities here and there as needed, like heat and cold and that sort of thing. And then we do tell them this, this is something that you do need to do. If you need to stand for 8 hours a day as part of your work, that's what you need to do. But before you go in the morning, do this. And then when you come home, do this. And if you need to take a break from standing, take a break, take a walk, do some backward bending, and then go back to it. And it goes back to what you said about the reset. Like when you're sitting poorly and then you go back to sitting, you're a little bit better. It's the same thing with prolonged standing or anything like that. But I think, the buy-in is extremely important. It is difficult to get, sometimes they don't necessarily want to do it. And a lot of times too, I think a misconception of physical therapy, and probably your field as well, is that, they kind of come in and then you heal them and they leave healed, and that is great. And I would love to be that person that can do that, but a lot of times, it's not just, physical therapy anyway, at least over the years has evolved. It's not a passive discipline. It's not something where you come in and we do things to you. That's not how it goes. There have been countless studies where it compared the effectiveness of treatment with manual therapy and exercises, specific targeted exercises versus a passive program. Passive meaning heat, electric stimulation, ultrasound, and that's it. Now, that's all the feel-good stuff, and that's great, and it feels good for while you do it, but there's no long-lasting relief from it. Now, things like, electric stimulation and heat, I think those are great things to do in the beginning of a treatment if a person is super flared up and, they're just in a lot of pain and if they're so guarded that they cannot move and get you to do the things, or you can't get them to do the things that you need them to do to make this better, you're not going to get anywhere. So you have to combat the pain first, So if we're going to do something like a modality to get them to that point, that's okay. But that's something I can say in our clinic, once they are able, then we'll start on an active warm-up versus lie on the table with some heat. And then at the end, if after they're doing all the things that they've done, and if they want ice to cool everything down, that's totally fine too. But there's no magic in those things themselves. Like all of the things
Absolutely,
are
yeah.
the actual interventions that we're doing. Because there really is substantial research behind, targeted exercise plus manual therapy
Yeah.
versus general exercise versus modalities versus, just cardio alone,
And since you're mentioning a lot of studies and a lot of support for this, McKenzie has been validated in many different studies and
Yes.
in many different ways.
Yeah.
To your point, this is something also a discussion that I end up having a lot with patients as far as this the attitude or the thinking, because sometimes we'll talk about it and they'll say, well, what do I do now? I say usually the first thing, as long as they can tolerate it and as long as the pain is not out of this world and they can't function, physical therapy. That usually will take care of it. This usually is not only the first modality of choice, but is the modality of choice and usually will resolve the issue. And what happens then? Well, then we can try different things, or at the same time, we can do interventional techniques. But is it possible that I will need surgery? It's possible.
Mm-hmm.
Well, why don't I just do surgery and just fix it? And this
Well.
is right. And this is the conversation where there is no such thing as fix it in our bodies, and certainly not in our spines.
Mm-hmm.
Our spines are dynamic, and having that conversation, and getting that buy-in from someone, because a lot of times when we talk about the potential surgery, and we talk about, I usually recommend, well, continue doing your therapeutic exercises because your recovery is going to be easier and better, and
Right.
you will end up needing to do that afterwards, because any tools that we employ, modalities like heat and ice, injections, surgery, they're just escalation of tools in order to get you to a plateau where you are stable and pain-free and functional and able to live your life.
Mm-hmm.
But then none of them are fix it.
Right.
It's all a matter of what tool we need to use to get you there, but then it's really in your hands, and it's really that's a conversation. And
Yeah.
that's inevitably a conversation that has to happen almost with everyone, and sometimes it's a longer conversation, sometimes
Yeah.
it's an easier conversation. So when someone, we're talking primarily about spine, right? And so a lot of the times spine can be tricky, right? And I'm sure you've seen some patients that they're coming in thinking that it's something else, and it ends up being spine. Before we started recording, you had mentioned that there was a case that was kind of peculiar and interesting.
Yeah.
Could you talk about that?
Yeah, there was a patient that I saw years ago, and she came in with a diagnosis of bilateral rotator cuff tear, which I found very unusual. And so when I was evaluating her, we're going through her history, there was no clear mechanism of injury. There was nothing that happened that would have necessarily torn both of her rotator cuffs. Now, I asked her if she had any film done, any imaging. She said no. She did not come from an orthopedist, so she came from, and this is not insulting any profession at all, but it was an assessment that I think was based largely on her subjective responses, which were she had difficulty lifting up her arms. So yes, that sounds like it is shoulder related.
Sure.
But the fact that it was bilateral is what kind of stood out to me. Like if it's on both sides and there wasn't any specific incident, it would just be very unusual that both shoulders tore out of nowhere at the same time, causing her pain and difficulty to move. So I assessed her neck. And that was the first thing I assessed, because typically with anything with the shoulders, again, specifically if it's both sides, or anything with the lower body, you do want to rule out any involvement from the spine. So in this case, it sounded a little bit peculiar because she was, describing pain in the shoulders, pain that went down, further down one arm than the other, but still going down both arms. So it sounded like it was nerve related.
Right.
I did an assessment on her neck, and she did have limitations. She did have a reproduction of symptoms. She did have certain motions that did take away her symptoms. She had a positive clinical prediction rule, which was, there's 4 things in a clinical prediction rule that indicate cervical radiculopathy. For her, 4 out of 4 were positive.
And cervical radiculopathy is a pinched nerve in the neck.
That's right, yeah. Pinched nerve in the neck that causes symptoms in the arms. So with that, I was really convinced that, okay, there's no way this is not coming from the neck. So I treated her, and in 5 to 7 visits, she was completely pain-free. She was able to fully move her arms, and we did just the neck. We did mechanical loading of the neck. We did repeated motion of the neck. We did strengthening of her postural muscles. We did strengthening of her deep neck flexors, which is strongly correlated with people with chronic neck pain. And she was great. When she came in initially, the thing that she was told was she would likely need to have bilateral rotator cuff repairs. And she said, because the doctor told her physical therapy didn't make her better, then she would get an MRI. And depending on what the MRI showed, then she would likely need the surgery. So she was extremely worried about this, rightfully so. But, she ended up really great. So that is just, one of many examples where like the neck or just the spine overall can't be ruled out. And the benefits of doing a systematic assessment in a way that, does the repeated motion, checks your active range of motion, and sees the effect of what these motions are doing to the peripheral joints.
Yeah, no, that's a great point. And sometimes I'll see some patients that are referred for assessment and evaluation from an orthopedic surgeon who does see a rotator cuff tear, but sees that there's more to it. And so, because they want to make sure that what they're doing is actually going to help the patient functionally, and it is truly what's causing their pain. So sometimes it ends up being a nerve conduction study, perhaps looking further and getting an MRI of the cervical spine to see if there is a pinched nerve, because there were studies that show that there are a number of cases where people come in with shoulder pain, true shoulder pain, and actual impingement signs, and they go through surgery and they're still left with some of the pain.
Yeah.
And a lot of it really comes back to cervical radiculopathy, pinched nerve in the neck. So by far not all.
Yeah.
But if that exists, it's great to see that come through from orthopedic surgeons that specialize in shoulders, and they want that ruled out or they want that eliminated to see how much they still have the pain if there is, especially when there's a partial tear. When there's a complete tear and there's discontinuity of the fibers, they have to reattach it in order to prevent it from atrophying and from them not being able to do it later. But when there's a partial tear and there is potential contribution from this to the overall symptoms, because we know how things are in medicine, and a good example of that is labral tears in the hip, whereas 15, 20 years ago, every labral tear got a repair. Every labral tear went into surgery. And then it was realized, well, not every labral tear needs surgery. So surgery was put off. It's like a pendulum. It swings too far one way, too far another, and then it finds somewhere in the middle where, some people actually do need some surgery. Some people would do well without it. And so, absolutely. So that assessment is crucial.
Yeah.
To get back to the actual continuity of the treatment, what do you usually advise for people, and what's a good transition? They've gone through the regimen. They are much better. Their radicular radiating symptoms into the extremity are much better. Even their axial or the pain in the back is better, right? What now? How do you transition patients to their daily? How do you graduate them?
So we have the benefit at our Plainsboro clinic to be within a fitness and wellness center. So, and several of our clinics do. So we'll often recommend that perhaps, and they don't need to join the fitness center that we're within, but to just join a fitness center. And then we do give them exercises to start off with. Most of what we give them though are things that they can do at home, and they're like just very basic, stretches to maintain their mobility, stretches to maintain the disc reduction, because again, I'm saying disc because that is often the issue.
Sure.
But to maintain that, and often these are not. There have been studies that have looked at the amount of exercises given to patients in physical therapy and their rate of compliance. So it's not a shocking study at all. Like the more you give them, the less compliant they are.
Right.
So I remember as a brand new therapist, when I didn't know any better, I would give them every single exercise they've ever done in physical therapy as a home program, because I'm like, well, this is great. So when they're done, they can continue doing all of these. So I would give them, a bunch of exercises, and it would be great if they did them. I believe that, and I still do. But then I just, over time, I know that like the likelihood that they're going to, do all of these to the degree that they did them in clinic, it's just not likely. So they found that if you give 3 to 4 at max exercises to patients to continue with at home, they're much more likely to do it. And like we were talking about before with the buy-in, if they see that it worked for them in clinic, I do think that they are more likely to do it. So that's typically one thing that we'll do. We'll also tell them to engage in some sort of like regular cardiovascular activity, whether it's brisk walk for 30 minutes, whether it's bike riding, whatever they want to do that doesn't aggravate anything else. Because if someone has like knee pain, you're not going to tell them to, jog,
Right.
But if it is something that they can do, cardiovascular is really great. It gets the endorphins flowing, it gets the blood going. It's good overall, just for nourishment of the spine, and it is something just for overall wellness that should be done. So that's something that's strongly recommended.
How long do you feel is sufficient for someone to do on a daily basis? Let's say you give them several exercises to do. What do you tell them as far as time commitment? How much time do they need to set aside that realistically it accomplishes what they need to do, but also is realistic within, let's say, a busy schedule?
Yeah. So the exercises that we give them as a home program, I mean, I can speak for what I do for patients, it will not take more than 10 minutes, and 10 minutes will be long.
Okay.
So it would probably take less than that. So it's like, because there are things that are designed to do typically first thing in the morning when you get up out of bed. Like when we sleep, right? Sleep is also really important for disc health. That's when they like nourish and they're at its most volume in the morning. So the greatest chance for disc herniations tend to be in the morning. So it's, I've told patients, like, try not to excessively flex in the morning. Try to do these specific exercises like the lying on your elbows or like pressing up. Try to do them first thing in the morning before you start your day. So yeah, but they don't take very long at all. It's like, and I do them every morning because I've had back issues myself, and it literally will take me maybe 4 minutes. So.
Well, I'm very happy to hear you say 10 minutes, because that's what I tell patients. I said, can you find 10 to 15 minutes a day in your schedule? That's all it's going to take. Because a lot of the times when I ask them, are they doing the exercises, they say some days, because some days are just so busy, I just can't find 45 minutes. Like, whoa, of course you can't find 45 minutes every day.
Yeah.
And there's, it's just not realistic. As much as it could be great that you do that, but it's just not realistic.
Right.
And I usually tell them that what I use myself, and I do the exercises every morning as well, and I tell them we need to trick ourselves. We're just not going to be consciously, we're going to fall off the bandwagon. We're not going to, if it takes effort to think about what you need to do, it's not going to happen.
Right.
So just like we leave the house and not brush our teeth, it feels weird that we miss something. Similar thing has to happen if you miss those exercises. And I've been honest with everyone I talked about this. I've had trouble getting myself to do it consistently. So all I did is I figured out my routine in the morning, and then I sandwiched it. And I said, well, I do it after this, but before the next thing. And it just became such a normal part that I cannot simply go to the next thing
without doing
this. And that just became habitual, but as a good habit. And so I try to tell them, just find the trigger. Whatever the trigger is for you. You pick up the newspaper, don't pick it up. Your reward for doing the exercises is to go to the paper, whatever that may be. So I just find telling them, and some people say that it helps them, but I just think we give ourselves too much credit that we're going to be responsible for our own health, and making a decision and being responsible, I think, is great. Finding some ways to trick ourselves when we just don't feel like it.
Yeah. And I think like people have, for the most part, I think people's intentions are good. Like they want to do it. They know it'll help. They know they should do it. But, life gets in the way and the morning gets crazy and they can't always do it and the dog ran out and there's all these things that are real life things why they can't. But you're right. If you make it part of your routine, like before I brush my teeth, this is what I will do, then you're more likely to do it. And you only have to do it a certain amount of times before it does become a habit. And now you have to do it, and it's just part of your day. So that's a typical transition. Is we'll give patients like 3 to 4 exercises to continue with at home, and then we'll give them some strengthening stuff. A lot of times I'll integrate strengthening stuff into their day. Like if we've done a ton of core stability stuff in the clinic, I'll tell them like just. Even if it's just to increase their presence of mind with it, like as you're going through your day, draw in your abdomen, like, pretend you're putting on a tight pair of pants or a belt and hold that position. You will let it go because you will forget about it. But then when you remember again, do it again, so just kind of giving yourself a little bit of grace to like, okay, I forgot about it, but let me just get back to it, because that you don't even need to make time for. It's just you're doing it as you're doing all your other normal daily stuff, And just one quick thing about core stabilization, like, that's another thing that's been studied pretty extensively. I think core stabilization, is important. I think with a lot of people, specifically with chronic back pain, it's been shown that the transverse abdominis is weak in those people. Now, it's hard to say, like, perhaps like these people had a weak transverse abdominis and that led to the back pain, or chronic back pain causes a weakening of the transverse abdominis muscle. So it's like a chicken or the egg. You don't really know what happened first. But the good news is it doesn't really matter. So it's like if we're helping the back and if we're strengthening the transverse abdominis, then, both are kind of getting there. But at the same time, it's not a cut-all, this is like what you and I were talking about before. There's not a cookie-cutter approach to treating these patients with back pain. So what worked for, your neighbor across the street for back pain may or may not necessarily work for you. I don't recommend that it's all tried. Right. A lot of people seem to think like, I have back pain because my hamstrings are really tight. There really is no which I was actually surprised, but I read this like years ago, that there is not any direct correlation between hamstring length and low back pain. Like a lot of times people's hamstring could be tight and their back feels fine, or they have back pain and they have tight hamstrings, but one doesn't necessarily lead to the other. So you can stretch out the hamstrings and now they're perfect, but their back can still hurt if that's all you're doing. Right. Same thing with core stability. Core stability is good, but it cannot be the only thing that's being done if that is not the only deficit. Right. So a lot of times, like, you need to get the mobility back, you need to get, the disc back where it's supposed to go, you need to improve like the overall mechanics. And then if you strengthen the core while you're doing all of that, that makes sense. But if that is like the sole focus without necessarily being any instability or any deemed weakness, then you're not really doing any good. You know?
Right. No, that's a great point. Great point, and great point on the fact that what worked for your neighbor doesn't necessarily mean that it's going to work for you. Even if someone else has tried it, that may just happen to be one of their weaker links, and that was enough to get them a bit better. But that's not going to engage everything that they can do in order to in order to improve or to maintain and prevent it.
Yeah, and I think that's one thing about our field is that we do have the time to spend and to assess the patient and ascertain their individual areas of deficit and their individual dysfunction, and then we create a plan to target that.
Right.
So it's not like here's a sheet of exercises, do these, because like we follow up with these folks, right? So we see like, okay, what is the effect? Do you feel worse? Is it going worse down? You're like, okay, let's reassess all this and try again. It's the same idea as if your neighbor across the street also has high blood pressure and you feel like your blood pressure is getting high and you just take her meds, like you can't do that.
Right.
So it's the same idea.
Good point. Yeah, absolutely.
It's the same idea. So like people's bodies are so different. We have patients all the time asking, my husband also has back pain. What do you think he should do?
Right.
And I hate giving the answer of like, tell him to come in for an evaluation, but that is, I would be doing him no justice at all if I said like, have him copy your program.
Right.
Like, you know what I mean? Because it may or may not be working for him, and I feel like that's just not, it's not doing him any justice at all. It's just kind of throwing exercises and seeing what sticks.
Yeah, absolutely. I mean, that's one of the reasons I have no handouts for sample exercises for the back. I do have handouts for things like plantar fasciitis.
Oh, yeah,
because I'll
I think
say,
that's different.
look, these are the couple of things that you can do, because the concept of plantar fasciitis is not simple.
Mm-hmm.
It isn't. But you can do certain things to start with that will have a good chance of helping you, right? Stretching and massaging and a number of different simple things that you can start doing. And if that doesn't work, if you are resistant or say that you don't have enough time to go to physical therapy, look, we can try these things.
Yeah.
But when they say, just give me the exercise and I'll do them, I try to explain there is no such thing. There is no cookie cutter. There is no handout. And I, like you said, I'd be doing you injustice if I would just look them up and give them to you, because I simply don't have the facility or the time to go over and really do everything that you need done to determine what is actually needed.
Yeah.
And so that's why for the back, for the spine, it is crucial and imperative to really make sure that someone assesses and someone who knows what they're doing really figures out where your weaker links are, where your it's strengthening and stretching, and it's mobility with flexibility. It's not it's strength with flexibility, which creates mobility, right? And I try to explain it. It doesn't, because some people say, well, I stretch every day. Well, that's first of all, general stretching is not going to do it.
Right.
But second, stretching is not going to do it, because you can't just have flexibility without proper strength. And sometimes the muscles that are tight for a reason.
Right.
They're compensating for something else, and you need to get rid of that something else, the reason that they're tight to begin with, in order to create that mobility.
Yeah. And I always tell people, like, it's like if there is a train on a broken track, and if you think that the train is the problem and you fix the train, but the track is still broken, it's still not going to run right.
Right.
So you have to get, to the core of it, It's like if if I'm having a heart attack and my arm hurts and you give me an ice pack on my shoulder, it's probably not going to do anything to the heart attack. So it's like, you have to get to the core of it, and you have to. And those people, we get those folks too, who say like, I exercise, 3 times a week. I do yoga. I'm very flexible. But then clearly that's not doing it, right? So there has to be something else going on. And it's probably not a flexibility issue for those people, but there is something else that's going on that needs to be assessed. So it might be like a mobility issue in terms of like the spine itself, not necessarily the flexibility of the muscle, like your lower extremity muscles. You know what I mean? Like your hamstrings might be okay, but your vertebrae still may not be moving as they should, and it might be limiting, so you're like, and like what you were saying, it's putting stress on certain areas, and the body will always take the path of least resistance. So if it has more motion here, that's where it'll take from. And if this is tight, it'll remain tight because it'll keep taking it from here. So that's what all it needs to be overall assessed to see like where the imbalances are, and then address it that way.
Yeah, absolutely. And that's also part of the conversation that I have sometimes. I do yoga and I do Pilates, but I'm still in pain. And so I usually say this: look, this is your sport, and that's terrific. But you know that athletes get hurt, right? And they don't just go back to their sport to make themselves better. They need to rehabilitate the injury, and this is what you have. You have an injury that needs rehabilitation, and you cannot just say, I'm going to keep on playing tennis because that's my sport and it's going to make me better, or yoga, or Pilates, or fill in the blank.
Right.
You cannot just keep on doing the same thing thinking that that's going to do it. For some reason, no matter how great your form of exercise is, it's not doing it, just like you said. So we've covered a lot of aspects of McKenzie, different aspects of physical therapy. It would be silly to say that there would be one thing, but if I was to ask you, what would be one thing, one takeaway for a patient, for our listeners, what would you tell them? If there was one thing that would to take away from this conversation, what would that be?
I would say if you have back pain, or if you have neck pain, or if you have pain that's going into the arms or into the legs, to get an assessment prior to trying things on your own. If you're not able to get an assessment right away, I would say to be mindful of what your symptoms are doing with the different positions that you're in, and really start to pay attention to them, because whenever you do get the assessment, these questions will all be asked. So if you notice that if you're sitting down, it's increasing the pain in your legs, try standing up and seeing what happens. And while it sounds really obvious is to get out of the position that's painful, it's often not thought of. And people think that, sitting is resting, I need to rest, but that's not always right when it comes to the back. Mm-hmm. So for patients, I would say, for patients going through physical therapy, no pain, no gain is not true. But at the same time, you do need to pay attention to where your pain is and the intensity of your pain. And the primary thing I can say specifically with the McKenzie approach is the concept of centralization, which the goal of all of the exercises and all of the manual therapy that is done, if you have pain in your arms or your legs that's coming from the back, is to get the pain out of your arms and your legs and get it towards the neck or towards the back. And those are things to be mindful of. So if things do hurt initially, pay attention to where they hurt and let your therapist know, let your physician know exactly what is making it worse and what is making it better, because the only way we know is based on what you say. And the only way we know if, we are reducing the derangement in your spine or decreasing the pressure of the nerve that's getting impinged is by your symptomatic response. So it's really important that you're as clear as can be. And also it's really important that you are invested in your own healthcare. This is, it is not physical therapy is not a passive modality anymore as it was years ago. There is no evidence behind that shows that only passive modalities work. So it very much requires, active buy-in of the patient, and you have to be invested and you have to be willing to do things on your own.
That's great. So, yeah. That's awesome. Well, I really appreciate it. I appreciate the time and I appreciate all the information, and I'm sure our listeners will appreciate it as well.
Happy to be here. Thank you very much.